similar to adults, in children, we need to have this framework if, let's say, we are assessing a child presenting with stridor. So the causes of stridor in infants and children is briefly divided into apyrexial causes and pyrexial causes, meaning whether the child presents with fever or not. So for apyrexial cause, the commonest cause is laryngomalacia. This is under the category of developmental because as a child grows older, the disease will tend to fade away and undergo spontaneous regression. Other common causes under the category of congenital causes are subglottic stenosis, cyst, webs, and vascular anomaly, and we can also have foreign bodies causing stridor in children. Okay, what about pyrexial causes? They would include these disease pathologies: acute epiglottitis, acute laryngotracheobronchitis, a croup, diphtheria, and abscesses. So we're going to talk about laryngomalacia. So laryngomalacia presents with a typical symptom of inspiratory stridor, and it is fairly much positional. So most of the time they present with stridor at supine position. If the baby is lying on the lateral side or on the prone side, the stridor will disappear. So the onset is not at birth, but the onset is rather after birth. So it worsens as the child becomes more active, and at the age of 2 years, 90% of the patients undergoes spontaneous resolution. So these videos here shows the typical findings of laryngomalacia. Here you can see the short airway epiglottic folds and redundant mucosa over the arytenoid. And here again, you can see that the laryngeal inlet closes during inspiration, giving off the typical inspiratory stridor. Again, the typical endoscopic sign: short airway epiglottic fold seen here, redundant arytenoid mucosa seen here, and an omega-shaped epiglottis. So if you can notice, the supraglottic airway is very much closed during inspiration, causing the inspiratory stridor. So the airway management in patients with laryngomalacia is expectant. This means that we monitor the patient's growth, feeding, as well as any chest deformities. The chest deformities, the respiratory distress because of laryngomalacia causes this chest deformity. For example, pectus carinatum, pectus excavatum. So if the growth chart shows that the patient's weight is beneath the fifth centile, feeding is interrupted because of severe cyanosis occurring during feeds, we need to intervene these patients with operative intervention. So this only accounts for about 10% of the patients. We perform supraglottoplasty by addressing the obstruction. So if there is redundant mucosa of the arytenoid, we remove the redundant mucosa. A short airway epiglottic fold, we laserize the airway epiglottic fold. We can also make the epiglottis stuck to the tongue base by performing epiglottopexy. So in syndromic babies, PEP therapy or positive airway pressure therapy can be a treatment option. So other congenital causes, different than laryngomalacia, they present at birth, not after birth. They need to be diagnosed with awake flexible nasopharyngolaryngoscopy. So this is a very important thing to note. You cannot diagnose laryngomalacia before you exclude congenital causes of stridor. So example of these causes are bilateral vocal fold immobility, subglottic stenosis, cysts as seen in this picture here, false cord cyst, a vallecular cyst, huge vallecular cyst, webs, and also vascular anomalies. And congenital cause of stridor needs surgical intervention. So that is the primary reason why you cannot diagnose laryngomalacia before you have performed an awake flexible nasophryngolaryngoscopy. Okay, what about pyrexial cause of stridor? So, acute laryngotracheobronchitis, they present with a classic barking cough, in which the patient has a 2-week history of coryza, afterward followed by barking cough and noisy breathing. Sometimes the noisy breathing is inspiratory in nature, sometimes it is biphasic in nature if it involves the subglottic airway. So most of the time the child is fretful, they may be dehydrated, and if you can see here in this picture, The acute laryngotracheobronchitis is caused by a para-influenza virus. They present with a typical stipple sign on an AP neck X-ray, and this is treated expectantly by giving fluid and rehydration. However, if the patient has secondary bacterial infection, antibiotics need to be started. Acute epiglottitis, these children present with a toxic looking, they are febrile, 40 degrees Celsius, they are not fretful. However, they are breathing, then they are doing this it very silently. They present with a typical tripod position in which there is drooling of saliva because it is so swollen at the supraglottis that even saliva cannot penetrate in. They would rather leak the saliva through the mouth. Yeah, the causative organism for acute epiglottitis is Haemophilus influenza bacteria. So the typical sign seen on lateral neck X-ray is the thumb sign as seen here in the picture. These patients need to be intubated in a controlled setting using a smaller endotracheal tube by a very experienced personnel. Mind you, these patients may end up having mortality if, let's say, the airway is not treated as urgently as possible. Antibiotics is given, generally third generation cephalosporin. They are nursed in ICU for about 2 to 4 days. Once the infection has settled, then the patient can be extubated. Another cause is diphtheria. It is caused by Corynebacterium diphtheria, bacteria in which they present with a whitish plaque at the oropharynx which can extend to the laryngopharynx causing stridor. Airway is managed via intubation in select patients and even tracheostomy in patients presenting with severe respiratory distress. This condition is treated with intravenous penicillin, high-dose intravenous penicillin as well as antitoxin. Retropharyngeal abscess is a deep space neck abscess which can present with inspiratory stridor in the pediatric population. Most of the time it is secondary to a tuberculous infection or a neglected foreign body. So as a conclusion, stridor is a sign of airway emergency and we must manage the airway appropriately, and we can choose these different ways to manage the airway. Intubation, but the intubation has to be done selectively with very experienced personnel around. You may use certain instruments, for example, fiber optic awake intubation, CMAC, or even a direct laryngoscopic intubation. Tubeless jet ventilation is also another way to secure the airway, and these have to be combined with a definitive management for the patient. Tracheostomy itself is one of the very important ways to secure airway in patients with upper airway obstruction. So a good management of the airway allows definitive management and improves patient outcome in patients with stridor.